I invite our Vice President, Dr. Kailash sir, to introduce our third speaker.
Friends, I think the last topic was a little frightening and very depressive also, the complication of diabetes. I still remember 1970 when I finished M.B.B.S. My professor used to say, if you want to curse a person, just curse him, get diabetes. Because some nephropathy, in fact those days not much of complications were not known. But that time itself he said, curse diabetes for a person who ill-treats you. And I am seeing how much of complications can come. In fact, the way in which he put it, it looks like diabetes is predictable and preventable. That's what it looks like. So that's a good. Now we are going to come to the next important topic: the recent updates in OHA'S. In fact, in private family medicine, most of us use only oral antidiabetic drugs. Very rarely we use. If you are in a different field like a pulmonology, I never use insulin, so I always use only oral. Those days it was so simple for us. We had only two drugs, sulfonylurea and metformin. So easy to treat. That is 1970s, 80s and all that. Now it's become very complicated. The number of drugs have increased so much. In fact, I do not know many drugs when they say this, that, so many names, small names, they say it's so difficult for other than the medical. I still remember my incident which I can never forget in my house surgeon. In 1974 and all, in our pharmacy itself there are only two drugs, sir. I do not know, Dr. Tilley knows that SDT, MBC is the only two drugs available in the pharmacy. So when you go and sit in the OP, we'll keep on, they used to give a small slip. So I'll keep on writing SDT, MBC, SDT, MBC, and all slip and keep it ready. If somebody comes, he says, I have Talavali sir, indapadi. Vaitavali indapadi. Enna vali andalu ore drug da kodupom. I gave the drug to him. He said, sir, sorry, 3 people there were only two drugs for diabetes those days. It was so easy for us to manage. But now it's become very, very tough. And now we have a good speaker who's going to talk to us on this particular topic, Dr. SARANYA DEVI.K, M.B.B.S, MD General Medicine, PG Diploma in Diabetes from the Royal College of Physicians. There's a huge list. I'll try to make it short. She's proficient in handling ICU and emergency cases. She specialized in various departments, general medicine, diabetology, hypertension, infectious disease, and of course, during the COVID crisis, she had handled a lot of COVID cases. She's committed to providing excellent care to most of the patients whom she sees. Currently, she's working in Venkateshwara Hospital, Nandanam, as a regular consultant physician, handled a lot of COVID ward cases. She also works in Kosh Hospital, Tambaram, Chennai as a part-time consultant. Previously, she was employed in Mission Hospital in Tambaram and also had experience in Sri Balaji Medical Clinic College. She has excellent communication skills and good leadership qualities. I'm very happy to welcome SARANYA DEVI.K to talk on recent updates on oral antidiabetics. Over to you.
So, good evening to one and all present here. I would sincerely like to thank my medical director, Dr. Tilley sir, for giving me this opportunity, and also IMA Metro branch, and also Dr. Girija and Dr. Kailash sir, and also Dr. Rahul to have given me this wonderful opportunity. I think this is the last topic and I think I should finish it fast. So my objective is to define the treatment objectives in diabetes with OHA'S and also to develop the basic understanding of the different OHA'S which is available in the market and their merits and demerits. And also I would like to discuss this based upon our Indian perspective rather than on ADA, because ADA is difficult to use here, and once we start using ADA based practice here, we'll be out of balance. So I think we should consider both the cost factor as well as the patient benefit. So both will be taken into account in the treatment objective. So what we should concentrate on? So first of all, we should correct the acute metabolic problem which is present in the patient, and also we should have a long-term patient compliance and also long-term prevention and long-term goal in the prevention of both microvascular as well as macrovascular complications. So what are the things we should first identify? So other than identifying the acute complications, we should also see the other comorbidities which is present in the same patient, because once we correct diabetes but still the patient dies, then again the blame will be on the physician, because they will say you have not seen the other things which has caused death. Suppose if you are giving some OHs and that has caused hypoglycemia, and we have not addressed the cardiovascular benefit of the drug, so again we will be put into the blame. So we have to see the patient as a whole instead of just seeing the glucose level. So our treatment should not be just glucose-centric. It should be always multi-targeted. We should also target hypertension, dyslipidemia, tobacco abuse, and also alcohol, overweight, obesity, and everything should be taken as an equal goal in the treatment course. So why should we treat diabetes? Because it is the leading cause of end-stage renal disease and also major cause of blindness and also non-traumatic lower limb amputation and also cardiovascular risk equality. It's per se a cardiovascular risk equivalent. So the aim of our treatment is to bring the blood glucose as close as to the non-diabetic state as feasible, but we should always not have a strict control over the glycemic status, especially in an elderly and those with comorbidities and also frail patients and also very young patients like type 1 diabetes. Children as low as 5 years or even 6 years can be type 1 diabetic. So we should take all the things into consideration, but usually they don't come under OHA group, they usually come under insulin group. So our main concern when we give OHA to the elderly with multiple comorbidities, we should take everything in our mind. So individualistic therapy and targets, we should not aim to aggressively control hyperglycemia in the very old, very young and frail patients and those with serious comorbidities. And also we should have in our mind the side effects of OHA, and also we should regularly monitor for the side effects. And also we should aim for comprehensive CV risk factor reduction, which includes blood glucose, blood pressure, lipids, and also we should limit the tobacco abuse. So whenever it is possible, I think we can aim for tight glycemic control whenever it is possible. Whenever it is possible, not always. This is the ADA guidelines. ADA guidelines gives the fasting target around 8, not 80. We never go for 80 and we never target for 80 also. We always take RSSDI as our gold standard. 115 according to RSSDI. According to ADA, it can go as high as 130, but as high as 130 is not accepted because it is associated with both increase in microvascular complications and some amount of macrovascular complications, especially microvascular. And postprandial up to 180 as per ADA, but as per RSSDI it is only 160. But HbA1c both are into the same line, around less than 7%. So we have to individualize the treatment based on their comorbidities. So these are the different sites of action of oral anti-diabetic agents. I will come back to this again. So we will first see the anti-diabetic agents which is available in India, and some of the anti-diabetic agents are also injections other than insulin. So the only drug which has been in the market since 1950s is metformin. Fenformin was the first cogener which was introduced in early 1950, and it was propagated as the agent which could completely replace insulin, but it was a failed attempt. Later on it was overtaken by metformin because it had lesser complications like lactic acidosis. Even metformin can cause lactic acidosis, but only in a rarer occasion, but fenformin was notoriously associated with lactic acidosis, hence it was withdrawn from the market. Now got the insulin secretagogues which we have in our use are glibenclamide, glypizide, glyclazide and glimepiride. Glibenclamide and glypizide are now slowly becoming out of market and they are not in favor because of their adverse effects. And now the glycoside and glimepiride are into maximum use, but with comparison with glycoside and glimepiride. Glycoside has more favorable cardiovascular protection than glimepiride. Glimepiride has the advantage of longer action and once a day dosing. Glycoside, when it is not used as a modified formula, is shorter acting drug, but modified versions and extended release formulations have almost 24-hour action. Other insulin secretagogues like meglitinides, like ripaglinide and natiglinide, thiazolidine diones are the only drug which is in use nowadays is pioglitazone. Rest all drugs have been completely out of market. Alpha glucosidase inhibitors, acarbose, meglitol and oglibose. Oglibose is more better tolerated than acarbose. Oglibose is being widely used in India, but acarbose is being widely used in foreign countries like US. And DPP-4 inhibitor, dipeptidase 4 inhibitors. The newer drugs which is being currently in use are sitagliptin, vildagliptin, linagliptin and tenagliptin. The other gliptins like Saxa, Aloe and evogliptins are not being currently used in Indian market even though it is available. It is available, but we are not much in favor of the drug because of poor cardiovascular protection. They have poor COVT outcome, and those trials have proved that these drugs can have some poor and they have potential harmful effects on the cardiac system. So they are not being of much use, and they are very costlier drug also than the tenagliptin which is available. The next Cloud9 drugs are SGLT2 inhibitors which is being overhyped, but it is not overhyped, they are worth the hype. Canagliflozin, dapagliflozin, empagliflozin and rimogliflozin. And GLP-1 receptor agonist, they are injectable forms of drugs, and exenatide, liraglutide, but exenatide is not being widely used because there is some higher incidence of pancreatitis which is being now currently in use are liraglutide, Trulicity. Trulicity is the drug which is available in India, and liraglutide is Victoza and dulaglutide is Trulicity. Trulicity and liraglutide, these two drugs are being widely used if at all we want to use a GLP-1 receptor agonist. Liximatide, semaglutide are not being widely used, and semaglutide is the only GLP-1 agonist which is orally available, and it is way too costly. I think around 10 tablets will cost around 2,300 rupees, and patients will not come back to us, and only few patients who can afford for the drug can come back. Other agents which is being tried for control of sugars are hydroxychloroquine, seraglitazar, bromocriptine and cholesterol. Now we will see their sites of action. The alpha glucosidase inhibitor inhibits the alpha glucosidase enzyme which is present in the intestinal brush border, and thereby it inhibits the conversion of complex polysaccharides into simpler ones. DPP-4 inhibitor and GLP-1 receptor agonist are both like the same kind of person with the different names, but there is some difference in their action also, and they mainly increase the incretin effect. Incretin effect is, I'll discuss it later. Now we'll see the sites where they are. And sulfonylurea and meglitinides acts on the intestine as a pancreatic beta cell, and GLP-1 receptor agonists also act on the pancreatic alpha cell, and metformins and thiazolidines act on the hepatic glucose output, bromocriptine act on the hypothalamus, and metformin as well as thiazolidines act on the skeletal muscles, and SGLT2 inhibitors act on the glucose reabsorption. So now we will first talk about the oldest and most favorite drug, and still the number one drug is metformin. Metformin was actually derived from, it is a synthetic product, but it is from the French lac, it is a flower, and which was used as an anti-diabetic medication since age-old time. And it was found to have an active ingredient called guanidine. And the first synthetic guanidine was a fenformin, but it is withdrawn, as I said. Now the metformin was started, it came to use by 1950s, and still it is currently in use. And still the number one drug recommended universally, whatever it is, ADA, RSSDA or whoever it is, they recommend metformin as the first drug of choice. And the primary site of action of metformin is liver. It reduces hepatic glucose output. It activates the cyclic AMP kinase. What finally it does, that is more important. It inhibits hepatic gluconeogenesis. And also it increases tissue sensitivity to insulin and also increases peripheral glucose uptake. It also reduces intestinal absorption of glucose. And it also can reduce appetite and promote weight loss. It also reduces BP and improve lipid profile. And this is what we expect in a person with full-blown metabolic syndrome. The anti-diabetic efficacy is quite good. It decreases fasting blood sugar around 60 mg per deciliter and a HbA1c reduction of 1.5 to 2%. But hypoglycemia as such with metformin use is very rare unless and until the dosage was not adjusted according to the creatinine clearance, especially in a CKD patient. Also, metformin can prevent the progression of impaired glucose tolerance to frank diabetes, especially in patients with insulin resistance, because it helps the patient to recover from the insulin resistance. And metformin is contraindicated if eGFR is less than 30. That is very important. But you can use if eGFR is less than 45 with caution. But there is a note that you should not start a new patient with eGFR less than 45 with metformin. Already existing patient can continue with regular creatinine monitorings, because without, sometimes they can rapidly progress to less than 30, which we will not be aware if you are not monitoring the creatinine. And also heart failure, which is requiring repeated hospitalization, we should not use metformin because it can increase the risk for lactic acidosis and hepatic insufficiency and alcohol abuse. It can potentiate lactic acidosis. Alcohol per se can cause a state of ketoacidosis, and added on that metformin can cause very dangerous acidosis. Use of iodinated contrast material for radiological studies. Actually, this is not an absolute contraindication. If a patient is going for a contrast study tomorrow, we need not stop metformin today. But after the patient has gone for an iodinated contrast study, we have to monitor their hourly output. If their output is okay, then there is no problem with continuation of metformin. But if there is some reduction in urine output, they are at risk for acute kidney injury. Acute kidney injury can potentiate lactic acidosis with metformin, but metformin is not going to cause any AKI who is going for an iodinated contrast study. So what are the common side effects of metformin? Diarrhea, abdomen discomfort, nausea, metallic test is very rare, anorexia is quite common. But this can be prevented by the newer formulations like sustained preparations and also gel-coated formulations. They adopt a slow delivery system which can avoid these GI side effects, and also it's better to take the medicine immediately after food, which can avoid all these complications. Now, triple drug combinations are in much of use in the market, and these triple drug combinations can worsen GI side effects because those patients will be, most of the time, will be advised to take the drug for in favor of secretagogues 15 to 20 minutes before food. In that case, metformin can have a side effect. So it is just we are giving for the patient convenience and to reduce the pill load as a combination. But it can have some GI side effects. And it can cause mild vitamin B12 deficiency. Usually, vitamin B12, we overload patient with vitamin B12, so this is very uncommon. And lactic acidosis is very rare, and some patients can report evidence of ghost pills in their stools. This is nothing to worry. This is because of the newer preparations. The drug will be delivered, the drug will have an effect on the body, but only the shell, which is being currently in use to avoid GI side effects, can come out. These ghost pills have nothing to, that does not pose a threat to the patient or doesn't have any problem. Just reassurance is important. Sulfonylureas are actually derivatives of sulfonamide, and they reduce blood sugar levels to a very great extent. And the problem with them is they will reduce the blood sugar irrespective of the blood sugar level. Blood sugar might be 70. If the patient takes drugs, again there will be hypoglycemia. So it is not auto-regulated. It will keep producing the insulin. Mechanism of action was told as early as 1946. Now the currently available drugs are glibenclamide, glyphosate, as I said, the glyphosate and glimetride. These glibenclamide and glyphosate will be usually thrown out of the market in the coming era. So this is the mechanism of action of sulfonylurea. They bind to the sulfonylurea receptor which is present on the pancreas, ATP sensitive potassium channel and they cause insulin release. So if I think I will not go to the depth of the mechanism, then it will become a pharmacology. So what we have to know, we need to know the duration and the dosing. That is very important in our clinical practice. Glibenclamide dose can be theoretically given up to 20 mg, but we never go for this theory. Theory shows glibenclamide 20 and glypeside 320 and glycoside 20 and glycoside XR as 120 and glimepiride is 8. We take only 50% of the maximum dose in our practice. We should never go for the maximum dose. There are 2 points because they don't have the benefit when we, even if we give whether it is 4 mg of glimepiride or 8 mg of glimepiride, will have the same effect and the maximum dose may cause more damage to the patient than giving benefit. And the longest acting drugs are glimepiride, which can act for 24 hours, and also glibenclamide 24 hours. Glycoside, XR and MR can act even for more than 24 hours. So they are very potent drug. They can reduce fasting blood sugar by more than 40 to 70. Actually, it is a theory, it can reduce even more than that, and HbA1c can reduce 1 to 2%. Action is immediate. That's why we ask them to take it 30 minutes before the meals, or at least 15 minutes, 15 to 20 minutes. And not all patients will respond to sulfonylurea. Patients should have some beta cell reserve. Only if there is a beta cell reserve, while we give the drug, there will be some action. There is no point in trying this drug for type 1 diabetes. What are the contraindications? Hypersensitivity to the drug, which is very uncommon. Only hypersensitivity to antibiotic range of sulfonine drugs are there, sulfonamides are there, but this is a theory. As I think most of them would have not seen any hypersensitivity reaction. Renal insufficiency, there is a related contraindication, especially when creatinine is more than 2. We avoid giving sulfonylureas, but glycoside can be given with some safety, but with reduced dosage than we give for other conventional patients, especially when eGFR is less than 30. And hepatic insufficiency, we should not use sulfonylureas, and pregnancy, and also following immediately acute coronary event. Because that is the reason why we should not use post-acute coronary event, because it will reduce ischemic preconditioning of the heart, which can have a significantly bad effect on the heart. So we have to avoid immediately post-coronary event, but there is no problem with a patient who is already on sulfonylureas for years together, or patient who has been stabilized post-acute coronary event. They can continue after that for glycemic control. And type 1 diabetics, it is not going to act. And diabetic ketoacidosis, any OHA is contraindicated. What are the side effects of sulfonylureas? Main side effect is hypoglycemia, because it will keep acting irrespective of the blood sugar, but the newer drugs will act in accordance with the blood sugar. And the hypoglycemia will be very prolonged also. And we are also, to avoid this, we have to always start slow and step up slowly, and it can cause weight gain. Any drug which promotes insulin secretion can cause weight gain and hypersensitive reaction, which is very rare. The other secretagogue, ripaglinide and natiglinide. These are not routinely in use, but still can be used whenever we want to skip the insulin, because for the patient convenience. It is not a very potent drug, but it is a costly drug. It reduces HbA1c around 0.5% to 0.8. So it can be used in addition to other drugs available, so that we prolong the usage of patients switching over to insulin just for our practice and patient convenience. It is not it is not going to do good for the patient also. So this also actually acts on the sulfonylurea receptor, which is present in the pancreatic beta cell, but a different subunit in the same receptor. It doesn't have any effect on actually doesn't have any effect on the fasting blood sugar, but it has a significant effect in the postprandial blood sugar. So whenever there is a postprandial surge, we can use ripaglinide along with O.H.'s or some other drug. As a monotherapy, again the drug will fail. The common ripaglinide dosage is 0.5 to 2, but we maximally use 2 mg. And natiglinide, we are not in so much of use, and it is taken before meals. Usually it is not used as monotherapy, it is usually used in combination with metformin or other secretagogue. Alpha-glucosidase inhibitors, acarbose, migritol and O.H.'s. So their mechanism of action is inhibition of the alpha-glucosidase enzyme, which is present in the brush border of the intestinal cells. Alpha-glucosidase will convert complex polysaccharides to simpler ones, that is disaccharides and monosaccharides. Acarbose actually has two sides of action. O.H.'s will act only on the intestinal responder cells. It is a purest alpha glucosidase inhibitor. But acarbose also inhibits pancreatic amylase. So that's why there is an accumulation of complex polysaccharides in the intestine. So more amount of intestinal side effects. With O.H., pancreatic enzyme will convert the polysaccharides to simpler disaccharides, but further conversion will not take place with O.H., so lesser amount of GI side effects. Even then it can cause side effects, but it is lesser than acarbose. Acarbose, the maximum dosage is 50 mg TDS, but O.H. 0.3 to 0.9 mg per day. So this is the effect of glucose load in the blood. That is the without acarbose. So the reduction in postprandial surge is very significant with acarbose. It will start acting right from the duodenum, jejunum and also ileum. Flatulence, bloating and abdominal discomfort is the main problem. Alpha glucosidase inhibitors are useful for persons only who consume complex digestible polysaccharides. If some person is an artifact, there is no point in giving him O.H. We should go for other drugs. And also, if some patient is the one taking fresh juices most of the time, when he is having postprandial hyperglycemia, there is no point in giving O.H. because they are taking monosaccharides and disaccharides as such. And it can reduce, but Indian diet is usually rich in complex polysaccharide. It is the digestible carbohydrates. When I say there is a complex digestible polysaccharides, there is also another component which is indigestible carbohydrates. Indigestible carbohydrates have a benefit effect on gut microbiota, like inulin, which is being now currently added in all protein powders also, which is being in Cloud 9 now, inulin, chicory root, and all those are non-digestible complex polysaccharides. But this drug is going to act only on digestible complex polysaccharides. It can reduce HbA1c around 0.5 to 1% and also peak postprandial hyperglycemia around 20 to 80 mg per deciliter. But usually it is better to avoid night doses, especially in elderly with multiple comorbidities, because their meal might not be very rich in carbohydrate, or they might take only very limited quantity of meal. So they might have hypoglycemia at midnight, and once they develop hypoglycemia with O.H., they should always not eat something like peanut candy or something. They should take a simple sugar instead, because only then their absorption will be aided. Other things there will not be no absorption, so they will keep having hypoglycemia symptoms. And it is better to avoid in patient chronic intestinal disease, because there is no brush border enzyme, then no point in giving the drug. And also advanced chronic liver disease, and also adverse effects can be lowered by starting the drug as any drug, whether it is O.H., whether it is sulfonylurea. We should always start with the lowest possible dose and step up gradually. And it is better to be given with the first bite of food. Now again, this has become a theory because of multiple drug combinations. Now we'll talk about thiazolidinediones. The only available drug in the market is pioglitazone. Pioglitazone are now not being currently favored because it is favored by ADA, but it is not favored by the Indian setup because it has adverse effect on the cardiovascular system. It causes fluid retention and weight gain. So many adverse effects outweigh the benefit and outweigh the glycemic control also. So it can be added as the last measure to bring glycemic control in a patient who are not already in control. But we have to monitor for the response to the drug. If there is a good response with pioglitazone, then there is no problem in continuing the drug with regular monitoring for weight gain and fluid retention and other problems like hematuria and other things. But if there is no reduction in HbA1c or blood sugar even after 3 to 6 months of treatment with pioglitazone, then we have to either stop the drug and go for the rest of the options. So how do they act? They act on the PPAR receptor and they enhance insulin sensitivity. And how does they cause weight gain? Because they increase the uptake of free fatty acid in the circulation and promote subcutaneous fat, and they don't cause visceral fat. They predominantly promote subcutaneous fat accumulation and adipocyte differentiation. They also reduce triglyceride free fatty levels and also reduces insulin resistance and also increase glucose uptake in the skeletal muscles. but there is actually no increase in insulin secretion. They don't actually increase insulin secretion. And the one benefit with this drug is carotid intimal thickness can be reduced to some extent, because they take all free fatty acids which is present in the circulation and they convert and store it as a fat cell. So carotid intimal thickness can be reduced with thiazolidinase. They cause weight gain, fluid overload, and increased risk of heart failure, pedal edema, and also increased risk of fracture. That's why we should have caution when we use it in elderly men or a post-menopausal women. And also it can have a mild lowering effect on hematocrit. That is possibly because of the dilutional effect. It is not a true anemia. But we should have some caution when we already use in a patient with anemia. Better to avoid usage in a patient with anemia. And there is a probable increase in the diabetic macular edema. So we should, anyway patient will be subjected to yearly annual eye checkup. And also increased risk of CA bladder. This bladder cancer occurs usually when the pioglitazone usage crosses more than 10 years of usage. But when we regularly monitor for hematuria, this problem can be avoided. The strengths available are 7.5, 15 and 30 mg. We should not use more than that. And it can be given once a day without reference to meal, because their action is not dependent on the blood glucose level. And the effect will also take time for it to act. We cannot see any immediate effect. HbA1c lowering effect is 0.5 to 1%, 1.5%. It has favorable effect on lipid profile because it reduces free fatty acids and triglyceride in the circulation. So contraindication are patients with pre-existing heart failure and also pregnancy and also renal insufficiency because of both the same problem, because volume overload, and it should be used in caution with patient anemia and any fluid overload of any etiology, post-menopausal because of increased risk of fracture, and already a proven patient with macular edema is better to avoid. So what the government of India says, it should never be used as a first line drug of choice, and already a patient with active bladder cancer or unexplained hematuria, it is better to not give pioglitazone, and every 3 to 6 months we have to justify ourselves whether there is any use in the drug, whether the patient is actually getting some benefit with glycemic control. And also patient with known risk factor for bladder cancer, it is better to avoid the drug, and pioglitazone should be used in caution with the elderly. Incretin mimetics. So incretin mimetics, GLP-1 and GIP are the hormone from the gut mucosa which occurs in response to a meal. So this is the first distinguishing point from the sulfonylurea and the incretin mimetic. Sulfonylurea will act regardless of the meal, it will keep producing insulin just like a machine. But GLP-1 and GIP are physiological hormones which are produced in response to a meal. So when you don't take a meal, GLP is not produced. Only when the blood glucose rises, they start getting secreted. So they act by binding to the receptors on the target cell surface. The main target is the pancreas, both alpha cells as well as beta cells. And they also, the most important beneficial effect is, this is the only drug which can increase the islet cell mass. The other drugs which was previously discussed can actually exhaust or deplete the beta cells, which can make the patient to be completely dependent on insulin later on. So once we keep using sulfonylureas for years together, their beta cells get exhausted and finally they become complete insulin dependence. And also slowed gastric emptying suppresses appetite, so it promotes weight loss and also inhibit glucagon secretion and suppresses hepatic glucose production. So this is the comparison. We can see the pancreatic beta cell. The one side, the action is by the sulfonylurea and the meglitinides, which is causing insulin secretion. And even this is also causing insulin secretion, but a different receptor for GLP-1 and GIP. This is the incretin effect. Once incretin effect is seen only in response to a food intake, that is oral glucose only produces incretin effect. But whenever we give some IV dextrose, this effect is not similarly produced. So this is a glucose dependent insulin release from the beta cells. This is caused only by the GLP-1 and GIP. But sulfonylureas don't cause a glucose dependent insulin release. And also glucose dependent decreased glucagon from the alpha cells. So these two are the important actions. And it promotes glucose uptake by muscles and also decreases blood glucose in fasting and postprandial states. The next enzyme which is going to act is DPP4 enzyme. So these both are closely interlinked. The DPP4 enzyme will make the GLP and GIP to get inactivated faster. Their T half is very short. So now that's why we give DPP4 enzyme inhibitors like gliptins, which can make our biological GLP1 and GIP to have a better, longer half-life. But we cannot, now as of now we don't have GLP1 or GIP injectable form. We only have receptor agonist in clinical use, which is not practically conventionally feasible for the manufacturers because they are very short acting enzymes which can degrade faster with a poor shelf life. That's why we produce GLP1 receptor agonist. So this picture shows again the mechanism of action of GLP-1. They promote gastric emptying, they suppress gastric emptying, and also they promote glycogen synthesis and also promote insulin secretion and suppress glucagon. So we will now see the drugs which is being currently in use. Exenatide is not that much used. Liraglutide is being currently in use, but it should be given as once daily subcutaneous injection. Dulaglutide now has surpassed liraglutide in terms because it is not very potent, but it is just once a weekly injection. So once a weekly injection, and it will not adjust any dose for renal insufficiency, and it is not related to meals. The only thing what we have to exert caution in all GLP-1 receptor agonist is we have to see that if the patient is already having some familial risk for thyroid cell cancer, then we have to better avoid, because this all GLP-1 receptor agonists can promote C-cell hyperplasia and calcitonin release, but we will not regularly check calcitonin release. It is better to just avoid in patients with familial history of thyroid cancers or who are at risk for all men type 2 syndromes. And any type of types, exenatide or liraglutide, any types can cause pancreatitis. So occurrence of pancreatitis should be regularly monitored. And lixinatide is once a daily subcutaneous injection, and this also can cause pancreatitis. Semaglutide, usually we are not giving as injection. This is a orally available drug and this is very costly, and it can be given in the dosage of 3, 7 up to 14 mg per oral OD dosage. The only advantage is it is an oral drug and others are injectable, but the side effect profile is almost similar. The HbA1c reduction is only moderate, 0.5% to 1%, but still it has a favorable profile on the metabolic status of the patient, especially type 2 diabetes with obesity. It can cause weight loss and thus overcome insulin resistance and indirectly promote more reduction in plasma glucose. It is predominantly secreted by glomerular filtration, and hypersensitivity, type 1 diabetes, end-stage renal disease should not, and this is a contraindication. Type 1 diabetes we are not going to use, end-stage renal disease and also GI disease, and already a patient with pancreatitis we should not use. Advantages is it is a glucose dependent mode of action. So the risk of hypoglycemia is going to be very low, especially when it is going to be used as monotherapy. But when we are going to use along with the insulin sensitizer, it can also cause hypoglycemia because of the added drug. And weight loss is an advantage and favorable cardiovascular risk profile. That's why now it is being currently recommended as a first drug line of choice next to metformin by ADA. So approved by ADA and EASD as a second line preferred agent, second only to metformin. Other than that, they also can cause nausea, vomiting, headache, tachycardia. The next comes the inhibitors, that is DPP4 inhibitors, Sita, Vilda, Saxa, Alo, Lina, Teni and Evogliptin. We don't use saxagliptin, alogliptin and evogliptin. The most popular drug is sitagliptin, vildagliptin and teneligliptin, and the last drug is linagliptin. Linagliptin is quite costly compared to the other gliptins available. And the most potent gliptin among this is sitagliptin, next only to vildagliptin. Actually, teneligliptin is not that potent as it is promoted. Now we can see the maximum inhibition. So sitagliptin has the maximum inhibition of DPP4, that is 97%, vilda 97, and teneligliptin only 86 and linagliptin only 80%. But considering the cost of linagliptin, it is not that potent when it is compared with its potency. But linagliptin has the advantage that it can be given in a patient with CKD also. But other gliptins like Sita, Vilda cannot be given when creatinine is more than 2. And sitagliptin can be given as a once a day daily dosing also. Vilda is BD and teneligliptin mostly it should also be ideally given as BD dosage. For convenience it can be given as OD. Linagliptin is a OD dosage 5 mg. And teneligliptin we can give 20 to 40 and sitagliptin 50 to 100 or 100 to 200 also, but usually we give only 100 and vildagliptin 50 to 100. So they are orally active drug. It doesn't have any relationship with food. So it can be either given without food or without food, and it can be used as monotherapy or in combination with insulin or other, but it should not be used in combination with GLP receptor agonist. That is the only contraindication, because it doesn't have any potential benefit in giving both the drugs together, but it can adversely have more amounts of hypoglycemia rather. So whenever we give GLP-1 receptor agonist, DPP-4 inhibitors should not be given. Or whenever patient is already on DPP-4 inhibitor, either we have to stop and switch over to GLP-1 or give only GLP-1. But you can combine with other drugs like sulfonylurea, metformins and SGLT2. So pharmacodynamics have been already discussed. It increases the amount of GLP-1 and GIP in the circulation, and also decreases glucagon concentration, increases insulin and C-peptide. It primarily decreases only postprandial blood glucose. It doesn't have actually much effect on fasting, but by decreasing post-dinner sugar levels, it can have some effect on the fasting blood sugar. And it reduces HbA1c by 0.5% to 1%. It is usually the most well-tolerated drug. Even the side effect profile like GI intolerance is because of the metformin added to the gliptins. Usually gliptins as such doesn't have much of the side effects. Incidence of hypoglycemia is also very low, and acute pancreatitis have been reported with Sita and vildagliptin, but it is very rare. Even thousands of patients on sitagliptin or vildagliptin are doing very well with very fewer or lower incidence of pancreatitis. And rare adverse effects like joint pains and bullous conjunctivitis, these are only case series case reports have been occasionally reported. And the actual relationship has not been proven. And the long-term cardiovascular, this was what I have already told. Saxagliptin and also alogliptin have no favorable COPD trial outcomes. Next comes the most widely used and now currently being used, irrespective of whether patient is a diabetic or non-diabetic, it is an SGLT2 inhibitor. SGLT2 inhibitor is a sodium glucose co-transport protein which is seen in the renal proximal convoluted tubule and also enterocytes. But enterocyte has SGLT1. SGLT2 is seen in the renal tissues, in the proximal convoluted tubule. And the drug which you are using doesn't affect the enterocytes. It does not, because it has most deleterious effect. SGLT1 in the enterocytes is responsible for once it is inhibited, it will cause sodium and water loss in the intestine. Many of the microbes which is causing diarrhea also is going to act in a similar mechanism. That's why we don't want to use SGLT1 inhibitor. SGLT2 inhibitor acts predominantly only in the renal proximal convoluted tubules, and it inhibits the glucose absorption. That is actually a reabsorption which is happening in the proximal convoluted tubule. So this is the picture showing the proximal convoluted tubule cell. We can see the SGLT2 receptor is inhibited. So the glucose uptake, that is the reabsorption which is actually happening. The tubular lumen, this is the tubular lumen where the glucose is being going for filtration, and the SGLT2 receptor is taking in the glucose along with the sodium, but the sodium is not inhibited, only the glucose transportation is inhibited. So the glucose entering the interstitium is being prevented. Actually the renal threshold for glycosuria is 180 mg, but this SGLT2 inhibitor lowers the renal threshold even as much as 70 to 120 mg. So even if a patient is having 100 mg of blood sugar, it still can act, but usually it will not cause hypoglycemia. That's why now we are able to give better control, like even 5.6 in a patient who tolerates the drug very well without any effects of hypoglycemia. But previously, if you tried all those Accord trials and all those things, you did not use these kinds of drugs. These are only newer drugs. Now these has to be studied in depth. Even a non-diabetic patient with heart failure, we can give dapagliflozin without any hypoglycemia because it is a self-regulatory drug. It will excrete glucose only if the blood sugar is high, and once the blood sugar comes below 70 or 80, it will stop acting. What are the SGLT2 inhibitors available? Canagliflozin, dapagliflozin, M.B.B.S and riboglyphosine. And it can cause HbA1c reduction about 0.7 to 1%, and it also has a minimal risk for hypoglycemia. What are the doses range? Actually 5 to 10 is for DAPA and 10 to 25 is for M.B.B.S, and canagliflozin is 100 to 300, but it's very costly when it is compared to the other glyphosine. Other glyphosines have been made cheaper only now. During the launch, everything was uniformly costly. Only even a 10 tablet per strip can cost around 600 per strip. Now it has become a generic medicine, so now the cost has been reduced. Still, the canagliflozin has not lost its patency and it is still costly. So considering the benefit, so it is dapagliflozin and empagliflozin and riboglyphosine are now widely currently in use. Canagliflozin is not because of its cost. And dosage reduction has to be done when eGFR is less than 60 ml, or at least we have to reduce the dose when it is 45 ml per minute, because once the renal eGFR is getting decreased, the efficacy of the drug will also get decreased. It is not the drug which is getting accumulated and going to cause toxic effect. It is not so. Previously, which is seen with the other drugs. But the problem here is once the already a patient with eGFR of less than 45 has lost 50% of the nephrons, actually more than 50% of the nephrons. So in that case, we cannot have a proper PCT to act on. That is the reason why we have to reduce the dosage, and even it might not have a benefit in a patient with reduced eGFR. But now a new theory has come that dapagliflozin can act up to a patient with eGFR less than 25 ml per minute, because it individually decreases the intraglomerular pressure, and also it has a benefit on tubular hypertrophy irrespective of the glycemic benefit. So recent evidence suggests these agents may be safe even in a patient with eGFR less than 30. That is especially for dapagliflozin. And that trial is called the DAPA-HCKD trial, and one more is DAPA-HF trial. DAPA-HF trial especially concentrates on a patient with heart failure. A patient with euglycemia, that is a non-diabetic patient, can be prescribed with dapagliflozin of 10 mg OD just to have a natriuretic effect and also a cardio benefit effect, and it can reduce the frequency of hospitalization in a patient with NIHA 3 to 4 classification because of the independent effect on the ventricular contractibility. It reduces preload, especially when it is used along with diuretic and other drugs. When a preload and afterload is being reduced, it can promote ventricular contractibility, and also it can independently decrease the ventricular arrhythmia which can occur in any patient. So that's why it is known to have a separate cardiac protection which is irrespective of the glycemic control, and also it has a separate effect on the the tubular profile of the patient. It can reduce the intraglomerular pressure, it can reduce the tubular hypertrophy and has a favorable outcome on the nephrons. So it can cause all-cause mortality, and it can also improve CV outcomes, improvement in heart failure and renal outcomes. Generally well tolerated. The only side effect which we can say is genital mycotic infections, but one episode of UTI should not make us stop SGLT2 inhibitor, because diabetic patient can have UTI at any point of time. It is not SGLT2 that has caused an UTI. So one episode of UTI is not a contraindication. But even if patient is having a recurrent UTI, we have to see, is there any other problem which is causing the UTI, like urinary retention, poor urinary flow, BPH, and cystoscopy in case of a female, or any other problem which is attributed. Only if we have 100% clearance, this can be purely attributed. Some patient may be on SGLT2 inhibitor with poor glycemic control, which HbA1c of 11.5%, they can still have a UTI. That is not because of the SGLT2 inhibitor. And the symptoms can, especially in summer, they can have volume depletion because of polyuria and natriuresis. can increase both HDL as well as LDL, but their clinical implication is not known. And euglycemic ketoacidosis have been reported with SGLT2 inhibitors, especially when they keep continuing the drug in a view of a sepsis or fever or vomiting, or patient is already in a stage of dehydration. Bromocriptine we don't routinely prescribe it as an anti-glycemic drug. It can see, the bromocriptine which we use for hyperprolactinemia is completely different from a bromocriptine which is being used as a OHA. The bromocriptine which is used as a OHA is a it's an immediate release formula. The other thing which we give for hyperprolactinemia is a longer acting drug. This should be given within 2 hours of awakening from the morning time, because only then it can act on the hypothalamus and directly decrease the pathways which is involved in the hepatic glucose output. Once if it is taken very later in the time, it doesn't have any effect also. And actually it is working by controlling the circadian rhythm. So we should not confuse between the bromocriptine which is given for hyperprolactinemia and the bromocriptine which is given for glycemic control. The formulation is totally different. And dosage is 0.8 milligram tablets. It is taken a single per oral dose within 2 hours of awakening. Starting dose is 0.8, we can go up to 4.8. HbA1c is only 0.4 to 0.7 reduction. This can be used as an option to prolong the patient from switching over to insulin. Actually, it is better to always switch over to insulin as early as possible. But just for the patient's sake, just to prolong the patient, because even if I don't give, there is going to be some other practitioner who wants to give the patient, and they will be saying this doctor wants to give insulin always and he doesn't give insulin always. They don't actually understand the benefit of insulin, but they keep blaming the doctors. And side effects are nausea, dizziness, asthenia, and also somnolence and rhinitis. Hydroxychloroquine, it is a well-known drug to have effect on disease-modifying agent in rheumatoid arthritis, but whenever in those days, during anti-malarial treatment, when quinine was given, there was an effect of hypoglycemia. With that concept only, this was found to have an effect on the sugar levels, but it can reduce HbA1c around 0.5 to 0.6%. Not much, but considering the side effect profile, hydroxychloroquine is not being routinely used for a glycemic control. Saroglitazole, it is actually a drug which was indigenously developed in India, that's why it is not being promoted. If it is some foreign manufacturer who has produced the drug, it will be hyped like anything, just like SGLT2 inhibitors which was promoted like with so much of promotion, and it had a big price tag when it came into the market, but there were so many conferences and so many sponsors to promote the drug, but saroglitazole is not being promoted because it is developed in India. But still it can have a HbA1c reduction of about 0.5 to 0.8. Actually it can reduce even further also because of favorable lipid profile, especially a patient with insulin resistant with severe hypertriglyceridemia. When their lipid profile becomes normal, their insulin sensitivity also becomes normal. So this saroglitazole targets 2 parts of the insulin glycemic status. That is, it acts on both the gamma receptor as well as the alpha receptor of PPAR. So it regulates both the triglyceride levels as well as the sugar levels, that is the glucose levels. The dosage is 4 mg OD. Usually it is a well tolerated drug and symptoms are very rare: abdomen pain, fever, dizziness, as noted with any other drug. It is not a drug which is with so much of side effects. But this is also quite costly. And apart from being used in type 2 diabetes and diabetic dyslipidemia, it can be also used for the non-alcoholic fatty liver disease because of its action on PPAR receptors. Cholestyramine is actually a bile acid binding resin which is used for hypercholesterolemia, especially familial hyperlipidemia. This drug is being widely used for not for the acquired dyslipidemia, it is being widely used for familial hyperlipidemia. And this can also reduce glucose level, but it is a very modest reduction, 0.3 to 0.4%, and it can also increase for GLP-1 levels. But we don't routinely use cholestyramine for reducing blood sugar, but it is when it is used for other problems like hypercholesterolemia, it can also have an effect on blood glucose. Side effect is mainly gastrointestinal. I think this slide is not clear, but I'll say this is an American guidelines, just an overview of the guidelines. So when cost is, I think we have to see from this side. When cost is a major factor, they say we have to start with sulfonylurea or thiazolidiners. But in India, the cost is a major factor, but we don't go as of now by sulfonylureas. We should always start a drug which can protect patient pancreatic beta cell. They have to carry their beta cells even for 10 to 20 years. So we have to, universally we have to start with metformin and lifestyle measurements. But after that, this is a second line. I am talking about the second line. We have to start with SGLT2 inhibitors. Now the cost has been cut down. The SGLT2 inhibitor is not that costly. And next will be, then we can go for DPP4 inhibitors. And next will be in the line will be sulfonylurea. So sulfonylurea is the last drug of choice. And also thiazolidiners, that is still the bottommost line of drug of choice. This is order in case of an Indian setup, and also it is cost effective nowadays because the price tag has been reduced. And when we need to, especially a patient who is coming with 110 kgs, when weight loss is a concern and financial is not, most of the overweight patients financially they don't have a problem. They can spend one meal about 5,000 also in a party room, but they don't want to spend 5,000 per injection. But if at all they really want a weight loss, they have to spend for their medicines, because GLP receptor agonist will be the second drug of choice for overweight patient when their weight loss is a concern. They can lose up to, even depends on their insulin resistance and their food habits. Overeating might be a problem in few persons, and this decreases appetite. The estimated glycemic control is 0.5 to 1%, but some patient can become non-diabetic also if only overweight is a problem. So when weight is a problem, we have to start with GLP-1 receptor agonist or SGLT2 inhibitors, because even SGLT2 inhibitor can cause weight loss about 2 to 4 kgs, usually 2 kgs. And when they don't have control, the next will be, if they were already on SGLT2 inhibitor, go for GLP. If they are already on GLP, go on SGLT2 inhibitor. Still not under control, then go for sulfonylureas. And according to ADA, the next option is not even sulfonylureas. The next option is DPP4 and basal insulin. They want to start basal insulin when already a patient has crossed triple drug therapy. So metformin, GLP-1 receptor agonist or SGLT2 inhibitor. Then the third tier, again the same combo, and next will be DPP4. So all the above drugs, no effects. Then go for a basal insulin is the actual recommendation. But just to prolong the patient's insulin dependence, we can go for sulfonylurea or thiazolidiners. This will be repeating in the all columns. The next thing will be ASVD, when patient is having atherosclerotic coronary vascular disease. Then the first drug of choice will be either GLP-1, the first drug is like next to metformin, if metformin is not contraindicated. First drug will be SGLT2 inhibitor with a favorable cardiovascular profile, and also GLP-1 receptor agonist with a favorable cardiovascular profile. And the next column will be the same. Next column will be if they are on GLP-1 receptor agonist, then you can go for SGLT2. If they are already on SGLT2, you have to go for GLP-1. So it is just an interchangeable thing. The next will be, if still above the target, then we have to go for basal insulin, and then only they give thiazolidiners and sulfonylureas. But here we change the order, that's all. So already I have discussed about the cardiovascular profile of individual drugs and also the renal profile of individual drugs. So now I would like to conclude my speech. So what is the take home message finally? The current available pharmacokinetic drugs, many pathophysiological defect which is in present in type 2 diabetes, but metformin is a first line antidiabetic agent which should be included in every treatment plan unless and until it is contraindicated. Sulfonylureas nowadays should be used as a last line drug of choice whenever it is possible. And thiazolidiners have plenty of pleiotropic benefits, but we should also consider the side effect profile before taking into use. And also agents utilizing incretin system are often much in favor, and we should make it as first line drug of choice next to metformin whenever it is possible. Either it is GLP-1 receptor agonist or SGLT2 inhibitors. Next will be in line will be the DPP4 inhibitors. Whatever it is, whatever medicines have been prescribed to the patient, the final thing will be lifestyle management in diabetes. Dietary modification and physical activity should not be excused. They should be promptly followed along with the pharmacotherapy. And diet therapy in diabetes has to be individualized. We should not give a strict food diet who is type 1 diabetic. Type 1 diabetic already they are malnourished most of the time. They have to have some weight gain. So we have to individualize therapy. Whether if it is a type 2 diabetic with metabolic syndrome, then overeating has to be avoided. But there is now a very big propaganda that is anti-rice movement. Anti-rice movement, I don't know whether it was started by North or not, but it is rice is not something deleterious to our health. Rice can be taken in moderation, but there are people who take rice thrice a day, but that can be avoided. Rice products can be taken morning also, and it can be taken in different form, in like millets also can be included as a idli or whatever steamed products. Steamed products are actually number one healthy food available in the world. And it is now, but nowadays it is being blamed as idli is causing the most hyperglycemia and rice is causing the most dangerous hyperglycemia. If our lifestyle is going to be sedentary, then what point in just cutting down the rice? Some patients comes to us and say they don't take rice at all, and they say it very proudly, I am following no rice diet, but still my sugar is not getting control, I am not losing weight, because they don't walk. So basically what should be followed? Lifestyle measures has to be followed, which forms the integral part of the management, but they don't follow that, then they follow only no rice diet. So always diet should be as per the recommendations, and it has to be a balanced meal. Just avoiding one diet over the other is not a solution. A regular physical activity, which has to be individualized according to the age and their comorbid conditions, and patient education forms a vital place in any diabetes management program, because nowadays the YouTube and more of the social media propose actually anti-doctor propaganda. They say they can reverse diabetes within 1 month or 2 months of registration, but they are ready to spend even 1 lakh for that, but they don't want to spend for anti-diabetic medicines. If I prescribe GLP receptor agonist, they reject me and throw away, but they go for a promoter who says that they can reverse diabetes in 1 month and pay 1 lakh. So this is the actual and bitter scenario. So thank you.
Questions, sir? Anybody have any questions?
Like HbA1c assessment.
Yes, sir.
Is better for assessing prognostic value for
Definitely, sir.
not
HbA1c.
fasting sugar.
Not for fasting sugar alone is, yesterday patient might have had some millet breakfast, and next day fasting sugar might be 100. The same patient would have had a rice or some other thing, not just rice, something else. He might have even biryani also yesterday night, and fasting might be high. So HbA1c should be taken as gold standard. We should not just
That can be done only once in 3 months, no?
once in 3 months, sir. But still, it is theoretically 3 months. But there can be a change even within 1 month, but not within days or weeks. But the interlab variation can come. It can happen within hours.
So you should do the same lab very well.
Needs to show at least in a standardized lab. I have seen at least 2% differences in labs. One lab showing 11.5, another lab showing 9.5 on the same day.
Effect of hemoglobin on the HbA1c.
Definitely hemoglobin can have an impact, but same patient taking on a different day, on the same day cannot have an impact. But definitely hemoglobin, especially patients with hemoglobinopathy, HbA1c cannot be taken as gold standard.
Like low hemoglobin can falsely show a
Elevation.
Definitely.
I invite Dr. Kailash sir to honor our third speaker. Let's finish the session by national anthem.
Play பண்ணிட்டு.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा